Corey, thanks again for asking me to be here. So I know which one you would rather be, and it is just, it's for real. You know, this is, we all have seen patients like this, and both in our personal lives and in our practices. So it's no secret to anybody in the audience that elderly patients are undertreated. I mean, even though this is about decade-old data, and there's an expectation yet to be confirmed that today we do a better job with elderly patients, you see that the numbers are still quite poor when it comes to actual treatment of elderly patients in clinical practice, especially when we talk about combination, level 1 evidence, combination chemo to elderly patients. It's way, way below what's expected based on the frequency and prevalence of elderly patients with advanced non-small cell lung cancer, about 50% of all patients. So when we look at an elderly patient in our practice, you know, we sort of, and we're trying to make a decision, what do I do with this patient? Do I actually offer this patient chemo? Do I give single agent? Do I use a combination regimen? Do I use a platinum-based chemo, et cetera? The truth is, just going back to the comment I made a few minutes ago, we sort of use our gestalt to make that distinction. We don't have a tool that sort of guides us in terms of assessing risk, which is what we're trying to do, right? I think we have a sense of the evidence, perhaps even a sense of the benefit, but we don't know the risk, and we're all trained under this dogma of do no harm. You know, we don't want to hurt our patients. And what ends up happening often is, I think we do select out some patients that shouldn't be treated in the first place, or probably shouldn't receive combination chemo, but the risk of that risk assessment strategy is that we end up undertreating a lot of folks. And that's a realization that just recently we're beginning to have of how some of the elderly patients have been undertreated because we don't have objective guidance in terms of making that assessment. So Artie Huria has really been a pioneer in this field from City of Hope. And she and her colleagues in CARG and CALGB, no longer called CALGB, now Alliance, actually did or came up with a predictive model, as you see on the slide, with a different number of risk factors that predict for toxicity. So this is not about efficacy or benefit, it's about prediction of toxicity. You see the score for each of the factors, and these are elderly patients in general, not just lung cancer. And here's, let me make sure, hold on. Can I go back? Okay, and here are the numbers. If you have a high score, if you have a high score, no, actually I would say just anything above 9, you know, the risk of grade 3 to 5 toxicity is pretty significant. Now that doesn't mean that it can't be overcome, and it doesn't mean that patients shouldn't be treated, but it just means that you are aware of the fact that when you pile up those factors and you come up with an objective, reproducible score, you know, you need to be aware that certain toxicities are likely to occur. So it doesn't always help with the decision you have to make because, again, it excludes benefit from the equation, but it does make you aware of the risk. And I think that that's very important because we don't always know how to do that. Now, with that in mind, I think Huria's contribution is, as I said before, really pioneer and incredibly helpful in trying to bridge that gap as to how we make decisions in elderly patients in clinical practice. Now, just a couple of months ago, we were in Australia, and I had the privilege of discussing this trial as a discussant. And this is the Esogia trial from France. And this is by far the longest title of any trial I've ever seen. But what it says is it's a phase 3 study in which patients, elderly patients, are allocated to 2 arms. one based on MD decision, which is actually age and performance status, and we'll see that on the schema. And the other arm is actually a CGA, a comprehensive geriatric assessment, guided, allocated, or allocation. So this is, in my opinion, an incredible trial. So this is stuff that builds upon 2 decades of clinical research of looking into the different assessment tools and instruments that have looked retrospectively at clinical trials to try to understand outcomes in elderly, and yet this is the first prospective study in which the instrument is actually used to guide treatment. So it's an incredibly important trial. So this is the schema, almost as complicated as the title. But basically, what it says here is this is your MD-guided arm, right? You look at performance status as objective or subjective that you want to believe performance status assessment is, and then age. And here, if you are less than 75, you have a PS of 0 to 1, you get standard chemo, carbopem or carbogem. They did make a decision here, which they acknowledge now, that isn't necessarily level 1 evidence, that patients over the age of 75 or who have a performance status of 2 automatically receive single-agent therapy. And we know today, or hopefully at the end of this lecture, we'll know that that's not level 1 evidence, right? And then the experimental arm is based on the comprehensive geriatric assessment. Just for the interest of time, I don't have a slide on how that's done or the different components of the assessment. But based on those results, you come up in 3 categories: fit, pre-frailed, which I thought was cute, and then frailed subjects. And then you have fit getting the same treatments, pre-frailed, they get the single agent, and then they did exclude, which may be the most important contribution of this trial, the frailed subjects, and treated them with best supportive care. So they were able, according to them, or a priori, to isolate those individuals who should not be treated with any chemo. Okay? So, and the time to treatment failure is actually the primary endpoint, which is also an important endpoint for trials like this because it takes into consideration exit for toxicity in addition to progression or death. The disappointment, at least to me, I took this almost personally, to be honest with you, was that there was no significant difference between the 2 arms, really. So in other words, you can, it's the typical half full, half empty, right? And you can say, well, all this work that went into predicting outcomes of elderly patients doesn't seem to provide an advantage over clinical decision-making. Well, that's sobering, considering how many careers were involved in that sort of work, right? But you can always say, heck, we're not doing that badly, right? You know, we can still look at patients and age, performance status, whatever, experience, you know, clinical judgment, and we come out the same way. So what do we do with this information? Be great debate afterwards. So anyway, just to point out that the single arm here, at least in terms of time to failure-free survival, is a little bit lower. There were no actual or primary statistics applied to this endpoint, but it's important to take that into consideration. Best supportive care patients had a median survival of 3 months. Anyway, going back to the options of single agent, combination, this is stuff that Corey and I spent most of our career doing. These are some of the trials about 10 years ago when we didn't know what to do, GEM, vinorelbine, or the combination, the Swedish trial of GEM versus carbogem, our own subset in the carbopaclitaxel or paclitaxel alone. And there was a sense that the combination was better in respect to overall response rate, maybe progression-free survival, but overall survival was not obviously better with the combination until we had another French trial. The French do care about their elderly, actually, in many different ways, but that's a different story. And here you have patients aged 70 to 89. So this isn't that kind of trial that starts at 65, and says, this is the real thing. Performance status up to 2. And then they were randomized to either carbopaclitaxel, and I'll say just one thing about this, or either vinorelbine or gem. You could choose which was your single agent of choice. Now, importantly, the carbo here and the paclitaxel regimen was a weekly paclitaxel regimen. And I think that makes a difference when you use in populations like this. So carbo was day 1, and paclitaxel was day 1, 8, and 15 every 28 days. A little different than the typical carbopaclitaxel every 3-week regimen. Having said that, the doses were not modest. I mean, this was an AUC of 6 for carbo, which I personally do not use. And then paclitaxel was 90 milligrams per meter squared, which is pretty hefty, for this population or even this disease. Anyway, here are the patient characteristics. About a quarter of the patients had a performance status beyond 1, either 2 or a few 3. About 20% or so of the patients were never smokers. The median age here was 77. So this was not 72, 74, it's at 77. And there were patients all the way, as I said before, all the way up to 89. Here it is. So you had to have patients who are 89 years of age that you were comfortable randomizing to a combination arm, right? And here is the bottom line. So it was an overall survival trial, and the overall survival was clearly better in the combination. This is one of those beautiful trials, right? One variable, unequivocal results. You don't know, I don't know how many zeros are here, it doesn't matter. So it's 6.2 to 10.3. All right, so this is level 1 evidence. So from now on, we should be treating all of our elderly with combination chemo. You can choose this regimen, or you can say, well, we have other regimens that are well tolerated, and I don't have to go through the trouble of the weekly, whatever you want to do, it's not the point. The point is the principle, that these patients do benefit from combination. Is that, however, applicable to every single patient that you see in clinical practice? Probably not. And that was our hope for the CGA-directed, this is how these two trials come together, right? This was our hope for the CGA-directed intervention. In other words, there is a subset of elderly patients, I think we all recognize that, who probably shouldn't get carboplatin paclitaxel and won't benefit from it or will get harmed by it. We just haven't yet been able to identify those folks. Not at least other than just our own clinical judgment. So a couple of new data or pieces of data that have emerged in the past few months. So one was the point break. The point break has been discussed here before, so you know the design quite well. This was, however, a presentation that Mark Sosinski and others made at ASCO with a focus on elderly patients. This was a pre-specified analysis. And so this is for patients aged 70 or older, and there was no significant difference, just like there wasn't a difference in the overall population in the elderly subset for both PFS or, well, NOS. There is a statistical difference in PFS, just like there was in the overall population, but we all kind of passed by it very quickly, right? And so this is the data. So we reflected the data that we saw for the overall population, no difference. And here I thought was interesting. I really like this analysis too, because they gave us a little bit of the breakdown. So this is the so-called younger population. This was 70 here, and then older than 75. And I don't want to make too much out of this. I don't know the exact N here. But there was a numerical difference in the paclitaxel Bev compared to the other subsets. It's not the first time it happens. If you look at some of other large trials, when you get to 75 or above, especially 80, the octogenarians, you do see a numerical decrease. So that, I think, is an opportunity for us to look at the subset a little bit better. We all have been trying to come up with this notion that elderly patients, just by age alone, should be treated like everybody else. We invested a lot of our time and effort into this. When you get to 80 or above, I'm not sure that that same principle applies equally. It may apply, but I don't know that it applies equally, despite the French data, which took patients all the way up to 89. So it's just my personal bias. And then the second was, Corey was kind enough to give me his slides. I think he was still in New Zealand or someplace after Australia. That's what his email said, right? Not available. And this was about 2 weeks after Australia, by the way, so good for you, Corey. And this was another important question, which was, can we use Bev in elderly patients? And so despite all the caveats of combining studies in a retrospective analysis, I think that if you do this, this is as good as it's going to come out. In other words, from a methodological standpoint, this is a good and helpful retrospective analysis, right? And so what it takes is ECOG 4599 and Point Break. You all know now that they had the same treatment, carbopaclitaxel, right? And in ECOG 4599, they had carbopaclitaxel without Bev, and then in both 4599 and Point Break, they had carbopaclitaxel and Bev. So pretty reasonable comparison. And here's the data. So this is overall survival, this is PFS, and it sort of shows what we knew for everybody up until 75. When you get to the 75 plus population, which is one of the reasons why I made the comment I made in the previous study, it doesn't. Then there's actually a pretty noticeable shift in terms of what happens to these patients when treated with Bev. And I recall distinctly, I was there for Corey's presentation, that one of his conclusions was that 75 is the new 70, right? And I think that that's one message I'd like to convey here to everybody. Couldn't agree more. I think that if we're going to focus on, quote, elderly studies, whether or not that's where we need to put our efforts or not is a difficult dilemma. But if we do it, it should be a 75 and above. Let me see if I have another. And then what's important is the toxicity data, again, showing what the retrospective analysis of 4599 had already shown, which was that when you get to this age, you will have more significant toxicity. This is 8% versus 2%. It's not trivial. Now, like every piece of data that we see, it doesn't mean that you can't never, right, use Bev in a patient over the age of 75. If you do that, however, you do need to be aware of this, and you need to be incredibly cautious. So that's all. It doesn't address, it's not a same as level 1 evidence, but it's actually pretty relevant data, and it was really important for us to hear this. The other difference here, just for 1 second, is that the retrospective analysis of 4599, by the way, was for patients above 70. So here it does show that 70 to 74, right, the drug is safe. And you can use it. In other words, you can use it just as you would use in a 68 or 65. So that's another side of the study that I think is important. Anyway, moving on to performance status 2 patients. So first of all, I think everybody here knows this is not as Corey just said, if you put together elderly and PS2, that's the majority of our patients. So we don't have accurate numbers for PS2 patients in clinical practice. This is as good as it gets here. So it's about 30% of patients that are seen in an outpatient setting. Obviously, if you include hospital patients, it will be higher than that. I think when you talk about outpatient, it will be between 25 to 35%. Anyway, and so 1 in every 3 or 1 in every 4 of your patients will have a performance status that is less than 1. One important concept, one additional concept is PS2 is not the same as elderly. Even though for a long time we combined those two subsets, together in clinical trials as being, quote, ineligible for, combination chemo, or this is an important study that retrospectively showed that. This is Paul Hesketh and his SWOG colleagues, when in one of these trials that the two subsets were combined, there was a clear difference in outcome between elderly patients with a good performance status and PS2 patients of any age. So it's not the same set of issues. And they really ought to be, not just from a clinical research standpoint, that's for sure, but even in clinical practice, they ought to be approached, I think, differently. So one idea we had a long time ago was, well, if PS2 patients don't do as well with chemotherapy, or especially combination chemotherapy, despite the CLGB data, why don't we try something a little gentler, right? So this was in the early 2000s, and we said, we'll look at Erlotinib versus chemo. This is unselected patients. This is before the era of mutation selection, or any selection for that matter. The drug was approved for pretreated patients, period. So we did this clinical trial. It was a phase 2 randomized trial of Erlotinib versus carbopaclitaxel, right? In standard way, the same carbopaclitaxel that we had used in the CLGB trial, and then there was an optional crossover to Erlotinib. And clear results here. No? PFS, median survival time, 1 year, all in favor of the chemo arm. This was not a huge trial. It took only about 100+ patients to prove what then became obvious in subsequent studies, that you cannot use or should not use this drug in unselected patients in first line. Right? So this is sort of what became the main message of the IPASS trial, except that this was in PS2 patients. So doesn't apply. I think that's true. I didn't show data for EGFR TKIs as first line in elderly patients, but it's the same principle. And I think we've moved beyond that point in clinical practice. So then we decided to really sort of put an end to this question of single agent versus combination in PS2 patients, very much like the French had done in elderly patients. So we did a phase 3 study of carbopem versus PEM in PS2 patients. This was presented at ASCO in 2002 and 12. It has since been published in the JCO under Zukin, one of the lead investigators. This was a trial conducted mostly in Brazil with one site in the United States. So this is these are the two arms. These are the stratification factors and the eligibility criteria. And again, in terms of patient characteristics, most of these patients had adenocarcinoma, about 20% or so never smokers. What I think, and most of these patients had actually stage 4 disease. This is the older classification, of course, and about 35% of the patients actually were elderly by the 70 cutoff criteria. What I think is important here too is that we don't see a lot of severe comorbidities. So the sense we had, without doing a very careful analysis of comorbidities, which by the way we were asked to do by the reviewers, and we did the best we could. It doesn't seem like these patients had a performance status 2 on the basis of comorbidities, that their low performance status was mostly due to cancer-related issues. And here's the overall survival, which was the primary endpoint. Unequivocal difference in terms of overall survival, and median, 1 year, et cetera. And I think what was interesting is I put the two together. So if you look at the elderly trial, the French trial, and our trial in PS2, the curves look incredibly similar. A little bit of a difference, in terms of median, as you would expect, because as we said, age is not the same as performance status. So the overall numbers here will be somewhat lower, but the magnitude of the difference, the hazard ratio, seems to be almost identical between combination and single agent. So we would like to think that just like the French trial, this is level 1 evidence for management of performance status 2 patients. Now, just like Corey did for the elderly patients in a retrospective analysis, we actually, a while back, decided to look at this question of Bev in performance status 2. And in collaboration with the Sarah Cannon folks, we did this trial, just pure PS2 patients that were randomized to PEM alone as a control arm, PEM and Bev, or carbo-PEM and Bev. This was before the Brazilian study was done, or much less presented. And we had an opportunity to present some preliminary results in Australia. This is not the best way to show this data. This is all I had. And it doesn't look like the toxicities, the Bev-related toxicities for this patient population in terms of grade 3 and 4 were substantially different than you see for patients with performance status 0 to 1. That is our initial take on the data. We're still going through this, but it doesn't seem to be prohibitive in any way. I think that's an important observation, something we were trying to demonstrate. Now, as far as efficacy, it still is an open question. So can you use the drug in PS2 patients? Probably can. Should you use the drug in PS2 patients? I think it's still an open question. There wasn't a dramatic difference in terms of the addition of Bev, but the trial was a little complicated in that respect. If you look at PEM and Bev versus PEM alone, I think yes, right? But then when you add the carbo, it becomes a more complicated interpretation. So just to finish, okay, I have 58 seconds here. So assessment of risk in elderly patients can be done objectively by reproducible instruments. I think Hurria has shown that. However, it does not appear that at least when you use a CGA, which is not what she used in the CARG, the CGA-directed treatment is superior to MD choice. For elderly and PS2 patients, a carbo-based doublet leads to an improvement in survival compared to single-agent therapy at the cost of increased toxicity. Both in elderly and PS2, we saw increased toxicity, but the overall survival was impressive, or at least the difference was impressive. Targeted agents are best used in patients selected by molecular criteria, and Bev can be safely used in PS2 patients, but not perhaps in the old elderly, as Corey's data suggested. Thank you very much.